I'm going to ask our panel to introduce themselves. I'm going to try and keep it to 3 themes, if indeed we have time for 3 themes. It's obviously very much open to you to drive this, but the 3 themes I thought we could look at were transparency, then the issue of doctors as leaders, and then also the patient voice. So they're the 3 themes. So I'm going to start with transparency, but first of all, I'd like to welcome our panel who are going to introduce themselves to you. So Charles, would you like to begin?
Good afternoon, I'm Charles Ellis. A bit about my background. I spent my career working in the NHS as a manager, then developed MS around 16 years ago, which sort of ticked over gently, and then I had a very big relapse, which stopped my legs from working. Since then, I've got involved in health in a number of ways, through being a non-exec director and through voluntary organisations.
Okay.
Good afternoon. My name is Ros Moore and I'm the Chief Nursing Officer of Scotland and also the Director responsible for patients, the public, the healthcare professions, adult care and support at Scottish Government. I won't give you a rundown on my career, just to say if you're trying to place my Scottish accent, which part of Scotland I actually come from, don't. Because clearly I'm an interloper into Scotland. I come from the People's Republic of Yorkshire and a very happy immigrant up to Scotland.
Good afternoon. I'm Dr. Nayla Kamal. I come from Pinner in Harrow, if someone was wondering where I come from originally. Well, I'm a gynecologist by background. I've been involved, or I've been working for the NHS for the last 20 years. I'm an associate specialist. I chair the SAS committee for the Academy of Medical Royal Colleges, and I am also a clinical tutor and lecturer at Imperial College, London.
Hello, my name is Judith Half, and I am by background an anaesthetist, now retired from clinical practice. I currently work for the GMC. I'm the responsible officer and senior medical advisor to the GMC, but I am also now a non-executive director of an acute hospital trust.
I'm Ben Bridgewater. I'm a cardiac surgeon here in Manchester. I've had a responsibility for the programme to collect and publish outcomes data in cardiac surgery since about 2005, and since March this year I've been involved with the Healthcare Quality Improvement Partnership in terms of publishing outcomes more widely than that.
Okay, well, let's start on this theme of transparency then. And Ben, I'd like you to kick off with this because, you know, cardiac surgeons have really led the way in terms of openness of data. And very briefly, could you talk about the issue of transparency and how that is emerging?
Yeah, I guess in cardiac surgery, we kind of now embrace it. I think we didn't embrace it at first. When we got letters, each hospital got letters from the Guardian newspaper in 2005 after the introduction of the Freedom of Information Act. We all thought the sky was going to fall in, and we thought this was the worst thing that could ever happen to our specialty, our patients and us as individuals. But when that came out and we saw that actually we were praised for doing it, and actually we were stronger for doing it, and it changed our culture to be more patient focused, we realised that was a good thing, and we've tried to pursue that in a systematic way since then. I think it's interesting that one of the key recommendations which came out of the Bristol inquiry was about transparency and outcomes, and that never really happened in anywhere other than cardiac surgery. And obviously that's come out in Francis, and I think we have a real opportunity to take that and run with it, because I think if we are transparent about what we do, clinical outcomes, and particularly about patient experience across the board, I think the profession will be acting as a profession.
Okay, Judith, the GMC perspective on this.
Well, and the culture of openness is one that the GMC has talked about a great deal over the last 12 months, and particularly in the light of Francis. And indeed, it is in our guidance for good medical practice that if a doctor sees something that they are concerned about, they must do something about it, and they must say so. But I'd like just to say a little bit further about transparency. I would like us to see transparency, particularly in the medical profession, as a learning exercise. And I think cardiac surgery has admirably demonstrated that. The improvement in clinical outcomes, demonstrable improvement in clinical outcomes, because they've looked at what they do. I think also it isn't just between the medical profession, transparency. It is openness not within our healthcare organisations. And I think there is an imperative on anyone who works in healthcare to be transparent about what they do. And of course, a duty of candour has been prime amongst the Francis recommendations. And of course, our transparency with patients, but always being mindful of the sensitivities of patients and how we handle that transparency when we're talking to patients.
Nayla, in your area, how does the need for candour and transparency fit with the area of obstetrics and gynecology, which I think is the most litigious within the health service?
Absolutely. I mean, maternity is one of the main areas where a lot of concerns have been raised. I have to say that as dealing with medical students, teaching medical students, we are, driving in this message significantly. But when medical students become doctors and enter the real arena in the postgraduate, part of their working life, as an organization, we need to have enablers for them to actually practice, implement, and support the transparency. People want to do it, but what are the areas which actually stop them or maybe stretch them to think about it? So I think that is a piece of debate or discussion that needs to happen now, and it has already started happening, I have to say, and the main stakeholders are really looking at it with the sincerity that I, in my 20 years, have not seen before.
And Ros, obviously this applies equally to the nursing profession as well. What's your perspective?
Well, I mean, in terms of nursing, all the professions are facing the same issues. So I suppose I wanted to just comment on it as part of my role, which is privileged to be very close to policy making, but also to the delivery of service. So in the environment that we face, in terms of the challenges, global challenges, you don't need me to elucidate on those, including the economic situation, then having data to make good policy is absolutely essential. And therefore, data for policy, data for management, data for improvement, I think is absolutely at the bedrock of facing the challenges for the health service in the 21st century. In terms of getting down to it at an individual level, I think too long as professionals we've not accessed sufficiently the feedback from the people, either our peers or our patients, and the people that managers, in order to learn and develop, as my colleague said, and that's the process. If not, there is a tendency to assume you're doing really, really well and that everything's okay. So I think it's at the bedrock. The other thing I would say, it isn't just about data, it is also about information and publishing information. And someone, Niall, in the introductory statement, talked about the culture of suspicion that the media generated. My own personal experience as a senior civil servant and senior manager in the health service is that the degree in which you're transparent and publish information and put it in the public domain proactively, that reduces that and it changes the dialogue then that you have with the media, and you have, because it's not then about why didn't you tell us that, it's about, well, why is that like that, and what can we all do about it? So transparency for me is the bedrock of a modern health service.
And Charles? Yeah, viewing it from, I guess, the patient angle, the fact more information is made available to everyone who's sort of looking at the health service, but probably what's as important is the fact that maybe by being transparent, being open, we create some kind of cultural shift, which means patients that feel free to say what they feel, how they feel, ask questions, challenge, and have a voice. And I know we're going to talk more about that later. But, I mean, just the fact that you can walk into probably 99% of hospitals now and see a big banner poster which is asking patients, friends, families, carers to give their opinions of what this hospital's like. And similarly for GPs and for community care as well, which is equally important, that's their sort too.
Okay, let's open it up then to the floor. I mean, there was certainly a very strong feeling from the workshop I was in that if you do speak out, that whistleblowers, for want of a better word, do themselves damage, although that it was also agreed that it was essential. So I wonder about that tension between transparency and reporting things when they go wrong. Yes, under the row there.
There is an important element of transparency, and this is the transparency of politicians regarding what is available and what is not available on the health service, which is transferred in the very old NHS Act. The Secretary of State of Health was responsible, directly responsible, about your health and mine. And now this has been transferred down the line into local CCGs. And it needs to be transparent in that respect, as it is in Holland, for example, where every element of health that is available on a national health service is quite clear to the patient representatives, to the doctors, and to the providers.
Okay, so you're talking about transparency of what the NHS can do and what it can't do.
Yes.
Okay, all right. Other points, please? Yes, right up the back there in the middle of the row. And anybody else who has their hand up? Just so we get the mics near you. I'm sure we've got stuff on Twitter as well. I'll have a look on my tweet feed. I'm not playing a computer game, I promise.
We looked at the transparency in the medical profession as a part of our poster, and I was just wondering how you thought patients interpreted the data, because actually when we were looking at it, we found it quite complicated, and how you think that will affect the way that they, maybe access healthcare.
Who'd like to come in there? Ben, yes.
Yeah, I think you're absolutely right. And transparency is an interesting thing. And I actually think it's a real shame that we as professionals need transparency so badly, because transparency has had to be forced on the profession. People haven't been proactive about thinking, what do my patients want to know about the services I provide, and putting it out there. It's really been a system whereby the medical profession has always been reactive, which is a real shame. But what we do know from cardiac surgery is when you start to collect this data and you publish data, you actually make people aware when their performance isn't as good as it should be. And actually, once they're aware, they will take action. And actually, if it's transparent, they will be forced to take action because people will be on their backs about it all. But it's only when we make it transparent that we get everybody to engage in those quality improvement activities, and we actually get that quality improvement shift. So there's no doubt about it that transparency drives quality, and the magnitude of the effect is absolutely enormous. If anybody invented a drug which reduced your mortality for cardiac surgery to 30% of what it was, you'd win Nobel Prizes for it. And that's the sort of effect that we've seen from transparency. So it's actually very good and very important, even if it's not understood by the patients. When it's understood by the patients, then it's even more powerful, because actually that enables people to make choice. It encourages shared decision-making. And speaking from the perspective of the H-grip and the role that I've had about publishing those 10 outcomes this year, we deliberately let it float. We deliberately let professional groups take their own course of action on that, because we were trying to encourage it to be done quickly, and also to try and pick up best of breed from that. And what we found is that as an experiment didn't really work. So what we're now doing is some much more detailed consultation with patient groups to understand what they're looking for from this data, so that we get it more consistent for the next iteration, which will happen next year.
Okay, Ros, do you want to come in there?
I said earlier on that you use data for different purposes, and therefore the sort of data that you want as a user of services compared to the data that you may want in order to make good policy or to make resource decisions is very different. So I think the trick for us is just making sure that we really understand what information it is that is the most meaningful and useful for the people that we serve, and presenting it in such a way as that it is. And in Scotland, as we do across other parts of the UK, you have a number of excellent patient groups and public associations, etc., who really turn our information into really accessible information. People with learning disability communities like that, they really, really know how to present information without in any way eradicating its veracity or reliability. They just present it well. So I think it's a challenge, but it's something that we should work in co-partnership. But I have a real clear belief that we should publish everything, but not everybody wants to look at everything.
Okay, Charles?
Just really thinking that it's really important that information is clear. And when you, I mean, I can view it from two angles. One as a patient, one as a non-exec director, where, you know, I get sort of once or twice every 2 months, get sort of presented with massive agendas, with loads of information that's not very accessible. From a patient point of view, I think the NHS has got a duty that it needs to make that information as simple as possible for everybody. And that does mean everybody, not just sort of, you know, the well-informed middle classes, but everybody else who can see, and through patient groups. I think Rosie's point about providing information that's accessible for people with learning disabilities is really important. And one of the groups that I go to has got fantastic agendas. The information is produced beautifully.
Fabulous stuff.
For that to be understood. And I think we could all learn a lesson from that.
Okay, comment from down here, yes.
As a medical student, I completely agree with the idea of being transparent, but I am worried about a legal duty of candour and whether that would open us up to more litigation.
Who'd like to come in there?
Well,
Nayla, yes, please.
Yeah. I mean, when we talk about ethics in law, and I mean, there are whole different concepts of morality, what is morally right, what is ethically right, and what is legally right. There are clear frameworks when it comes to legal protection or legally dealing with a clinical matter. And it is not actually hiding details from patients, it is following a process. And when it comes to being ethically correct and morally right, those are the areas where we can emphasize more to be more transparent. With regards to legal issues, we have to follow the process and, you know, be transparent in their own way, whether that information is available to all that is in legislature.
Okay, yes.
My name is Shehnaz Somji. I'm an ENT surgeon. I'm also legally qualified, but I have another very important hat. I'm the daughter of a man who was killed by the NHS in the same way as the Staffordshire patients were before my eyes. And 3 members of my family were killed by negligence. I saved the life of a 4th when they were trying to kill him. Now, I accompany my family members to the hospitals and to GPs sometimes, but they don't know who I am. I sit there, I listen to what the doctor or sometimes nurse say to my relatives. They give them false information, they feed them with packs of lies about their condition. It's so disgusting that in the end, I have to come in and tell them who I am. And when they realize I'm a doctor and they've been lying to the patient, they start sweating, trembling, they get very worried, they don't know what to do. This shows that there's a lot of dishonesty in the system. You can't trust them. I'm very concerned that something has to be done about it, and it's got to be by some form of legal teeth.
But as a doctor yourself, I mean...
I've always been honest with my patients, so I get a shock when I realize that my colleagues don't have the same attitude as me. I've never misled patients. I'm a locum doctor, but whenever I go to a hospital, they always say, "Can I see you again next time?" And I say, "Sorry, I won't be here next time." And I ask myself, why is it that I'm not going to be here, and those who are here are clearly not satisfactory for the patient?
Okay, well, that brings us neatly on to the whole issue of doctors as leaders then, because trust and honesty are clearly vital to that. And let's start this way this time, just looking at, you know, are doctors in the modern NHS the right people to be leading multidisciplinary teams? Is it managers, nurses, patients? Where should the balance lie? Charles, would you like to start?
I mean, from my experience, I've been in different hospitals as a patient for periods ranging from sort of a few days to actually 2 or 3 months. And where you get a really good doctor in charge of a team and a multidisciplinary team with physiotherapists, OT speech therapists, it works really well. And as a patient, you are made to feel that you're involved, say, in a ward round, you know, you'll be spoken with rather than to, it'll be inclusive of you. And in that case, where you've got somebody who's a good leader, then it works really well. I'm not sure that all the time it's something that can just be sort of dumped on somebody. I think you probably need some training to be able to actually do leadership well rather than just pay lip service to it.
Ros?
A few years ago, well, it's more than a few years ago, I went to the Netherlands and just looked at the healthcare there and talked to a guy in an intensive care unit who talked about his role as the care coordinator. So he analogized it to driving a milk cart, and so he'd sort of put all these bottles of milk on the back. Some of it was medicine, some of it was physio, some of it was this, some of it was that, and he would drive the milk cart. And I think the driver of the milk cart changes, and it doesn't belong to any one individual as a consequence. So there are right times when the medic should lead the multidisciplinary team, but then as the person's care needs shifts, or indeed at the beginning of a care journey, it may be right for the nurse or indeed the physio in certain points to be the care coordinator. So I just think it's you know, we keep talking about multidisciplinary team working. We're yet, I think, to get to that parity of seeing the care journey as a collective whole that we all contribute to and deciding then who's the best leader. I totally agree with my colleague, Charles, that you need preparation to be able to work like that, to work in a collective, cohesive, shared responsibility, shared outcomes sort of way, and we're not at the moment educated to that. In terms of leadership in its more broadest sense, then I think we are all leaders and we are all followers, and that sounds very trite, but I could give you a long thesis on why I believe that, but I'll let my colleagues speak, and if I need to come back, I will.
Nayla, I mean, perhaps in no other area, but obs and gynae, there is a tension sometimes between midwifery and consultants.
No, never.
I don't know if you've ever come across that.
No, that's not true.
I would like to, I think there are many medical students here as well, and as an educationist, I'd like to bring in Laban Benger's theory, educational theory of communities of practice. So basically, when we are looking after a patient, everyone who is involved with the care is a community of practice for that patient. So anyone can be a leader driving a particular, clinical intervention or anything. So each one of the people who are in that team looking after the patients belong to that community of practice and should have leadership responsibility as well as following responsibilities. Now, I'd like to come to the point of of my experience of NHS, as we have heard some of the drastic stories. But without any bias, I have been working for the NHS for the last 20 years. I have been in this country for the last 24 years, and I have come across the NHS as a patient, as a carer, as a mother of someone, of a child who needs, intensive care in a very reputable heart hospital, which is internationally known, Hayfield, and also as an educationist involved with Imperial College and students. Now, there are areas where lapses are made, and invariably my experience has been then the system, the pressures, the demands have actually stretched individuals that they have been, stretched to, there might be a lapse of professionalism. But invariably, majority of the people I've come across are really sincere, good people who are really diligently trying to do their best to look after their patients in their capacity, and struggling with a system, with a culture which has been thrust upon them or has evolved over the years that they have no say in. So I think we cannot brush everyone with the same brush, if my English is correct, and the analogy is correct. And also, I think we have a responsibility amongst patients, amongst ourselves, to celebrate the good work that is being done by the individuals as well, because it boosts morale. Every time when we hear negative criticism, sometimes for those who are not really involved, although we all have shared responsibility because we are part of the same organization, it is very, very demoralizing. So I take that view as far as that's concerned.
Thank you, Judith.
Well, I'd like to come back to your comment about leading multidisciplinary teams, because I think the military actually are a fine example of this. The military have huge current experience of leading very acute teams, and the team leader is whomsoever is most appropriate, and it isn't always a doctor. That being said, I think that we produce in this country a cohort of doctors from our medical schools who are capable in very different ways of being leaders. Not everyone has to be a manager, for example, but nonetheless they do have, in all the areas that Nayla has mentioned, education and so forth, have various abilities to be leaders. Do we teach leadership well? No, I don't think we do teach leadership as well as we might. We're getting slightly better at it, but I think we have quite a long way to go with that. And not just teaching it, but recognising it.
Okay. And Ben?
Yeah, I'd build on that point. I think there's a lot of people who are doctors who are great leaders. There's many people who want to be leaders who are terrible leaders, and we're not very good at identifying which ones they are and then supporting them optimally to get where they can be. I had an interesting discussion with somebody very senior in our organisation who's interviewed a lot of managers and interviewed a lot of consultants, and their observation was that a lot of the doctors' sense of their self, their understanding of the way they are and the way they interact with other people was far, far behind that of managers who are managing the service. And I think if we are going to make these clinical teams function really well, they need to be well led, and that will often be led by a doctor. And to do that, these doctors have to equip themselves with a skill set which they currently don't possess to get to the optimal place.
Okay, I'm going to take a couple of comments on the floor, but I do want to talk about the patient voice. I don't want to be squeezed for time. Yes, down the front here.
Yes, thanks. Jonathan Beard, Royal College of Surgeons of England. Taking on Ben's point there, the question is, why don't we encourage health service managers to work and train more, in particular, with senior doctors? Or even at an earlier stage. It seems to me, my experience of health service management in the clinical directorate model is that it's rank amateurism. None of the clinical directors have training in leadership or management, and none of the managers, the health service managers, understand the issues of patient care. Surely we should be training them together.
Okay, I'm sure the Secretary of State heard that, so that's an interesting comment for him. Yes, the gentleman there in the third along in the row.
Yeah, I mean, I think one of the fundamental points here is actually about the measurement of quality. You know, that's what I sort of sense from this whole discussion. It's really trying to get to how do you know when you see a medical professional whether they're actually any good, to be quite honest. And, you know, GMC tends to deal with the outliers and the negative outliers, but the problem for most people is actually trying to get some visibility, some transparency around what adequate quality is. And this is just really one end of the spectrum. there have been some really good results with cardiothoracic surgery, I think, and they've benefited really well. There was a series in The Lancet recently which set out that statistically for a lot of the specialties that you're not going to have the power in an annual year, in a one-year time frame, to actually demonstrate mortality rates. And, you know, and people have used that argument to say, well, you know, it's very difficult for me to prove my quality on that particular indicator over a one-year time frame. I would turn that around and say, well, how can you tell me that you're any good, you know, based on that lack of information? Okay,
thank you for those comments. So let's finally, in the last few minutes, talk about the patient voice, and particularly in the light of the doubling of complaints about doctors in the last 6 years, and how indeed the medical profession should adapt to patients who are better informed than ever before, and often when they turn up at their doctor's surgery or in hospital, they know a good deal about the condition, or they think they do, from the web. And again, Charles, would you kick us off here?
Yeah, I think one of the issues here is that as a patient, when you're in hospital and when you're sort of spoken to or with by the team that's looking after you, sometimes it's not always easy to say what you mean and what you think. You know, as I said, I was a senior manager in the NHS for a number of years, was in hospital for sort of 2 or 3 months. And I know that despite the fact that, you know, I knew my way around the NHS, I knew my way around the staff, you know, I had a voice. That voice was lost, I think, as a result of my illness, and just as a result of how quick things were. And I think I wasn't always saying to the medical profession and nursing staff and others, you know, and even probably friends and family, what was actually going on. And I think there it requires a sort of canniness of medical professionals to actually use their intuition, listen to any voice, listen to even, you know, a whisper, what's being said, what you can see. And if you've got, you know, a concern or a doubt, talk to somebody about it. You know, also, you know, as a non-exec, I would say, you know, I would encourage anybody here who feels like they've got an issue that's going on to actually contact somebody senior in the hospital, contact one of the non-execs, contact the chairman, talk to them, and just thinking of the point you were saying about worrying about the medical legal aspect of things. I would hope that you would feel confident that if you went down that direction, you actually would be sort of spoken with in a way that makes you not feel like that.
Okay, I'm going to go straight to the floor now. Can any comments on this from anybody I haven't heard from yet today? Yes.
As a medical student, I've kind of come into this profession to, you know, be involved in the healthcare of patients, and therefore I'm becoming more and more worried by the influence of language that's coming in. The patient is being replaced by the client or the service user. How much of the kind of complaint increase is due to a more consumeristic approach to healthcare rather than a healthcare approach?
Yeah, Judith, should we worry about terminology, clients, customers, patients? We're all patients, aren't we?
Well, on a purely personal basis, they're patients, as far as I'm concerned. They're not clients. I think they're our patients, and I think all doctors understand the imperative duty they have to their patients. So let's not talk about clients. The increase in complaints to the GMC is pretty stunning when you look at it on a piece of paper, 100% over X number of years. But I think we need to remember that not all the contacts to the GMC are actually complaints about doctors. And I think one of the things that perhaps Charles was saying, if I understand correctly, is that patients don't always know where to go. So that informed patients think, right, okay, I'll go to the GMC. And I think that's a really big piece of work we have to do in healthcare, is actually to communicate to patients where they might bring their concerns about a whole range of subjects over healthcare that aren't, there may be a complaint about doctors contained in that, but it isn't only that. So we have a lot of work to do with that to make it much easier for patients to know to whom they can go, so that maybe it doesn't become a complaint. It actually becomes somewhere where they can express their views and have their views listened to and some feedback on that.
Okay, before I come to Nayla, yes, the lady in the middle there.
Hello, I'm Linda Paterson from the Royal College of Physicians. I think we're deciding that patient feedback's really important. I think it's a way to drive improvement and we can learn from it as professionals. Can I put a challenge back to the GMC as to why in revalidation we're saying we only need to collect patient feedback once every 5 years? Doesn't make any sense to me.
Okay,
do you want to start again?
Judith, quickly come back on that.
We have said that. I have to say, of the range of 6 pieces of information that a medical professional can bring to appraisal, patient feedback is probably the least well developed. Better developed in some areas of medicine than others. If you look at the returns and the comments from responsible officers, many healthcare institutions don't have a very well developed system yet. That is not to say that they should be developing it. I think we will see changes over time with that. At the moment, we're in very early stages of revalidation. And I think we really need to make sure that everybody does have at least one cycle of patient feedback. I hope that will change pretty swiftly as the systems come into play, because I think it's absolutely critical to the outcomes of our practice.
Okay, Judith, thank you very much, and thank you to all our panel.